Have you ever felt like a medical chart just totally missed the actual story of your health? Like all the messy nuances, the timeline, the human moments were just completely stripped away? Well, welcome to this explainer. Today, we're diving into a massive blind spot in healthcare. For decades, we've relied on medical data systems that look at health from this high-altitude bird's-eye view, focusing almost entirely on the disease rather than the actual person experiencing it. So we're going to explore a really fascinating alternative. It's called person-centered clinical analytics, and it's built around something known as the Avinash principle. We're going to see how visualizing the real, messy, human journey a patient takes can completely flip our understanding of clinical care, and why fixing this data flaw is absolutely vital for the future of medicine. Think about it for a second. Most clinical data tools do one of two things. They either reduce a wildly complex human being to a single, flat diagnosis code, or they zoom out so far that an entire population just becomes a summary statistic, an average blood sugar level or a generic readmission rate. And by doing that, we're literally throwing away the only thing that actually matters, the specific sequence of observations, decisions, and outcomes that a person actually lived through. We just lose all the context. When you simply average out the numbers, you completely erase the trajectory that a doctor actually needs when they're standing right there at the bedside, trying to figure out what went wrong and what to do next. To really wrap our heads around the sheer scale of this problem, let's just look at a simple snake bite. If you tried to map out every single biological branch, every physiological response, and every clinical choice for one snakebite case, you'd end up with roughly 244 million possible paths, from admission to discharge. 244 million. That's mathematically paralyzing. If a computer tried to calculate the optimal path through all those variables in real time, it would probably just crash. And yet human clinicians successfully treat these cases every single day in emergency rooms all over the world. They don't freeze up. So how do they actually do it? Well, obviously, doctors aren't running a search algorithm over 250 million branches in their heads before they act. They don't pathfind, they prune. A master physician can walk into a room, take one look at the patient, and instinctually ignore the vast majority of the data. They just tune out the managerial noise and focus entirely on a tiny fraction of critical nodes. It's like they're pruning a giant decision tree in real time, zeroing in on the incredibly small number of variables, usually way under 1% of the total, that actually carry the true gravity of the case. And this incredibly efficient instinct actually has a name. It's called the Avinash principle. Rooted in complexity science, it suggests that healthcare behaves a lot like a scale-free network. In these kinds of networks, a few critical hub nodes hold a disproportionate massive amount of influence. These specific hubs sit right at phase transition boundaries. Basically, they're the tipping points, the thresholds where one more tiny input could trigger a massive cascade in the patient's health. The absolute genius of expert clinical cognition is realizing you don't need to control the entire board. You just need to secure those specific hubs, and the rest of the clinical decisions will naturally self-organize toward the safest possible outcome. But here's the catch. These critical hubs aren't purely biological. They actually come in two very distinct flavors. First, you have explainable nodes. These are the ones perfectly grounded in medical textbooks, like insulin resistance driving a cascade of vascular issues. We are great at tracking those. But then you have the experienceable nodes. And these are the human narratives. It's a sudden financial stressor that means someone can't afford their meds, a severe sleep disruption, or, a missed appointment because their car broke down. If our data systems ignore this narrative side, we'll completely miss exactly why a textbook-perfect treatment plan still crashed and burned for a real patient in the real world. To fix this chaotic disconnect, person-centered clinical analytics does something really smart. It completely avoids inherent disease bias by forcing every single patient graph into a universal 4-stage skeleton. So instead of writing entirely separate code or creating unique models for different diseases, the system mandates this exact structure for everyone. Observations lead to a diagnosis, which points to an intervention, producing outcomes. By building every single patient's data graph with this exact same architectural flow, we make sure the structure of the data itself doesn't artificially bias how we view wildly different human conditions. It levels the playing field so we can finally compare apples to apples across the timeline. Let's see what this looks like in practice. Take a synthetic 16-year-old type 1 diabetes patient. Under our 4-stage skeleton, her terrifying high glucose and weight loss on day 0 are our initial observations, which quickly lead to her diagnosis. She gets a rapid intervention of IV insulin, stabilizes, and is successfully discharged. Great, right? But skip forward to month 8, and she suffers a massive, life-threatening recurrence. When we map her timeline, the cause wasn't some biological mystery or a drug failure. It was a missed dose while she was away on a school trip, a purely narrative experiential node that acted as a violent pivot point in her health journey. Now, when you strip away the timestamps and map these trajectories visually, the geometry of the data just speaks for itself. The contrast is undeniable. Type 1 diabetes is marked by these highly irregular, sudden, and severe acute spikes, exactly like our 16-year-old's terrifying ER visit. Type 2 diabetes, on the other hand, paints a totally different picture. It looks more like a smooth, slowly branching river of gradual medication adjustments and lifestyle changes. And the beauty is, the visual system isn't programmed to hand draw these differences. The underlying logic is simply reflecting two wildly different lived human experiences. So what happens when we zoom out from our single patient to an entire nested cohort of hundreds of people? Well, we can run everyone through 6 generic checkpoints, from the initial diagnosis all the way to their final disposition. We literally overlay their journeys on top of each other. Wherever 2 or more patients land on the exact same checkpoint value, their individual lines converge into a visually dense hub on the map. And wherever someone forks off and reaches a value completely alone, their path stands out instantly as a genuine, undeniable outlier. Check out what happens right at the escalation checkpoint in our synthetic data. The lines for our type 1 patients overwhelmingly crash into an emergency department visit. It acts like a structural black hole. 14 out of 18 patients fall right into it. Meanwhile, the vast majority of our type 2 patients safely bypass that chaos completely, stopping peacefully at no escalation. Instead of relying on a clinician to manually guess that type 1 patients have higher acute escalation rates, the graph organically reveals these structural hubs across the population. The data just naturally pools right where the clinical gravity is heaviest.
Now let's layer our 16-year-old's specific journey back over this massive population network. Instantly, we can see exactly where she aligns with the textbook trajectory and exactly where her path just fractures and veers off a cliff. That missed insulin dose on her school trip, it wasn't just a simple mistake. It was a critical phase transition node, a tiny, everyday behavioral input that violently altered her downstream clinical outcome. The analytic system doesn't need to mathematically calculate the significance of a field trip. It just visually flags that stark divergence, allowing a doctor's pruning instinct to zero right in on the real problem.
Which brings us to a really fascinating question. What if we took this exact same graph and completely shifted its center of gravity? Up until now, we've anchored everything around the individual person. But the beauty of this visual structure is its total flexibility. We can take the exact same interconnected data and just rotate the map. We can ask, hey, who else in this entire cohort shares this specific core intervention or diagnosis, and how do their unique outcomes compare to each other? And that is the pivot lands in action. If we select a comorbidity like hypertension as our new anchor, the network instantly reorganizes itself. It fans out to show us the 5 type 2 patients who share it and reveals that all 5 are concurrently on ACE inhibitors, while 3 require ongoing complication management. Just by turning the dial, we've reframed the entire narrative from what happened to one person to what happens universally across our population when this specific decision point is introduced. It's a total game changer for clinicians, allowing them to spot systemic patterns that would normally be buried in isolated charts. Now, it is absolutely vital to point out that what we're discussing here relies on educational scaffolds built with purely synthetic data. This isn't a diagnostic tool, and it is for sure not a replacement for a doctor's intuition at the bedside. A truly rigorous data system demands strict discipline. It has to explicitly name its data gaps and narrative confounders, like our teen's missed dose, surfacing them for crucial context without assigning them a false mathematical weight. It honors the core rule of data science. We can never, ever claim more causality than the underlying design actually supports. Ultimately, this nested cohort graph is what expert clinical pruning looks like when it's finally made visible. It takes that deeply invisible split-second cognitive process, the incredible way a master clinician instinctively filters a complex decision tree in their head for one patient, and it turns it into a tangible, explorable map. By visually tracking where patient paths inevitably converge and diverge across a massive cohort, the system lets those critical hub nodes surface completely organically. It basically proves empirically what the best experts have always known intuitively. So I'll leave you with this. If we can finally make this clinical gravity visible, how might we completely transform the future of medicine? By refusing to throw away the complex, uniquely human path a person took to arrive at their diagnosis, and instead analyzing the true biological and narrative hubs of their specific journey, we open the door to a radically more precise, person-centered era of healthcare. We move away from treating the average, and we get back to treating the individual. Thanks for exploring the Avinash Principle and person-centered analytics with me today in this explainer. Stay curious, and as always, keep questioning the average.